colleagues. Today I will present to you my talk about the updates in Behçet's disease treatment, in which I will present the recommendation extrapolated from controlled studies and some important studies, as well as from expert reviews. First of all, we have to acknowledge that treating BD or multi-organ disease such as Behçet's disease needs organizations where physicians experiencing in the disease can serve together, or in other words, in a multidisciplinary team. Treatment varies depending on the involved organs, the severity and duration of involvement, and the frequency of attacks. At the moment, there are no specific recommendations based on gender or age for any of the manifestations of BD. However, the age and early onset of the disease can influence the decision of treatment, particularly in ocular involvement. Starting with the topical treatment, we usually use the corticosteroids-based application for oral or genital ulcer, which can be presented as an oral paste such as triamcinolone acetonide or dexamethasone ointment for oral ulcers, and can be combined with antiseptic agents such as the combination of fusidic acid betamethasone for genital ulcers. But Bimecrolimus, which is known as Elidel, is quite effective as well in treating genital ulcers. Pentoxifillin gel decreases the duration and pain of oral ulcers. And either of these agents, when combined with colchicine, decrease the burden and pain of ulcers. Sucralfate preparation also is quite effective in reducing pain and promoting healing in both oral and genital ulcers. And with dressings which contain aluminum acetate, cause vasoconstriction and cause cooling effect, which is quite helpful for the early stages of erythema nodosum. Treatment of recurrent aphthous ulcers can also be employed in treating oral ulcers in Behçet's disease, which actually comprise using antibiotics and antimicrobial agents as a first line of treatment and using local anesthetic or analgesic as a second line of treatment. Going to the systemic treatment based on system affection, we will start with the mucocutaneous lesions, which can be a constellation of symptoms such as oral, genital ulcers, erythema nodosum, papulopustular lesion, and less commonly sweet-like syndrome or pyoderma gangrenosum. We usually start with the colchicine as a standard treatment for mucocutaneous lesion, but it is very effective when it's combined with benzosine penicillin, as study showed. Apremilast also has proved effective in the treatment of mucocutaneous lesions. And if these agents fail to control adequately the lesions, then azathioprine is indicated. Cyclosporin, interferon alpha, and anti-TNF agents are also effective in cases not controlled by the previous treatment. Thalidomide can be used cautiously in selected cases due to its well-known potential side effects. There were controlled studies on the levimizole, dapsone, zinc sulfate, and isotretinoin, which proved the efficacy of these agents in controlling the mucocutaneous lesions, but there haven't been recent publications about them. Methotrexate, pentoxifillin, secukinumab, and ustekinumab are also other alternatives. In acute and severe attacks of mucocutaneous lesions, oral prednisolone can be used at a dose of 40 to 60 milligrams for 2 to 4 weeks and a taper over the following weeks. And in this setting, if the patient hasn't started already systemic treatment, it is appropriate to start the patient on colchicine at that point. For treating articular manifestations, which is well known to be less aggressive in Behçet's disease, presenting as oligo or monoarticular involvement and more often affecting joints such as the knees, or ankles. Colchicine is quite effective in controlling such arthritis. However, if the arthritis showed less response to colchicine, then adding benzosine penicillin will be helpful. In recurrent arthritis, azathioprine should be indicated in that setting. Interferon alpha and anti-TNF agents may be used in severe but uncommon cases, as we said, that it's non-aggressive anyway, the arthritis of BD. Intra-articular injection can be used as an adjunct therapy for monoarthritis. There is no strong evidence to support the efficacy of systemic corticosteroids and NSAIDs in treating the arthritis of Behçet's disease, unlike the arthritis of other inflammatory conditions. There is limited data to suggest the use of ustekinumab, secukinumab, or anti-IL-1 agents as alternative options. For treating the ocular manifestation, it is quite important to early and rapidly suppress the acute inflammatory stage and to maintain the remission of the eye to avoid visual loss. It is usually recommended to start treating with topical eye drops of corticosteroids and mydriatics for the acute anterior uveitis. This can be combined with the subconjunctival injection of steroids. But this is again if the inflammation is just limited to the anterior part of the eye. But if the inflammation involved the fundus, then the posterior subtenon steroid injection, in addition to oral steroids, are indicated. If the patient enters into remission, there is no required treatment, but there is a need for close observation. However, if remission is not achieved, then adding azathioprine plus systemic corticosteroids should be warranted at that point. If there is no recurrence for 6 months, then the patient can continue on azathioprine. However, if recurrence happened or if the patient started with the posterior segment uveitis in the very beginning, then consider the combination of azathioprine and cyclosporin plus oral corticosteroids. And if this combination inadequately controlled the condition, then anti-TNF agents, particularly the infliximab or adalimumab, are indicated, or alternatively interferon alpha. There is a recent study actually showed the sustained response of uveitis to IL-1 inhibitors such as canakinumab and anakinra, so they can be used if anti-TNF agents inadequately control the uveitis. For the vascular involvement, nearly all the vascular events are suggested to have similar pathogenic pathway, mainly driven by the inflammatory mechanisms. Different types of vascular involvement can coexist in the same patient, but the treatment depends on the site and the type of involvement. When it is venous, and the typical sites such as deep venous thrombosis of the legs and arms, the mainstay of treatment then will be corticosteroids and immunosuppressive agents. And there is no actually data to support the preference, no valid data to support the preference of one immunosuppressant over another. However, if we are to choose, the choice will be among azathioprine, cyclosporin, or cyclophosphamide. In refractory venous thrombosis, then anti-TNF agents should be considered at that stage, in addition to the traditional DMARDs, or alternatively interferon alpha. And there may be, at this point, the combination of anticoagulants can be helpful. The association of anticoagulant to immunosuppressive is suggested in case of extensive thrombosis of larger veins, such as the vena cava. And in this setting, cyclophosphamide is preferred to other immunosuppressants. The triple association of steroids, immunomodulatory or immunosuppressive agent, and anticoagulants seem to be the most effective choice in case of intracardiac thrombosis. We have to consider the patient's specific bleeding risk when we are to prescribe anticoagulants, particularly the presence of aneurysms. For the arterial involvement, immunosuppressants should always be considered to achieve complete remission and prevent post-operative complications. And the combination of anticoagulants at that stage is just to reduce the risk of post-operative thrombosis. According to the alaa recommendations, for treating patients presenting with pulmonary artery involvement, there is a suggestion to start high-dose corticosteroids and cyclophosphamide, whereas the use of anticoagulant in this condition is negligible. In patients refractory to the first-line treatment, anti-TNF agents represents a life-saving treatment at that point. Eventually, this should be considered in addition to the surgical procedures such as embolization, lobectomy, cavitectomy, and decortication. For the neurological involvement, when patients present with acute or relapsing neuropathic disease, usually they should start on high-dose intravenous steroids at 500 to 1,000 milligrams for 3 to 5 days. This should be followed by slow oral tapering of steroids plus azathioprine. There is no standardized regimen of the steroids withdrawal. It depends mainly on the severity of the attack and the clinician's judgment on the clinical response. If the patient showed in the very beginning severe presentation or poor prognostic factor, they should be started on anti-TNF or cyclophosphamide. Among the poor prognostic factors is the parenchymal involvement, particularly the brainstem type involvement, elevated protein or pleocytosis in this CSF, primary or secondary progressive course, and relapsing during steroid tapering. There was noted no significant difference between the groups started on corticosteroids and azathioprine on one arm and those started on corticosteroids and cyclophosphamides in terms of the long-term outcome. However, patients with a severe disability at the baseline who were treated with corticosteroids plus intravenous cyclophosphamides had a longer event-free survival. The anti-TNF agents have been associated with a higher response rate. They reduce the risk of relapses and progression of disability. Other drugs such as interferon alpha, methotrexate, MMF, anti-IL-16 or anti-IL-1 agents should be considered in selected cases as alternative options. As we all know, cyclosporin should be discontinued or avoided in patients with neuropathies. For the venous sinus thrombosis, treatment is mainly based on high-dose corticosteroids and short-term anticoagulation. The longer-term anticoagulation may be considered in patients with relapsing disease and or hypercoagulable state. The immunosuppressive treatment is not usually needed at the first episode, but should be considered in relapsing cases, and the choice should be among azathioprine, cyclosporin, cyclophosphamide, and anti-TNF alpha agents. If we are worried about any concomitant neurological manifestation, the cyclosporin should be ruled out of this selection. The choice of treatment in general should be based on patient's characteristic, disease severity, and involvement of other organs. A phase 3 randomized trial comparing the efficacy and safety of infliximab to that of cyclophosphamide in severe BD vasculitis is ongoing. For the gastrointestinal manifestation, it is usually recommended for mild manifestation to start with 5-amino salicylic acid derivatives such as mesalazine or sulfasalazine, but for the severer form, azathioprine is recommended. And when it is most severe, high-dose oral or intravenous corticosteroids is recommended to be given at that point, but its routine use is not supported by high-quality evidence. If the gastrointestinal manifestations are unresponsive to the previous regime, then anti-TNF plus or minus thalidomide are recommended. There is some evidence suggesting some efficacy of methotrexate, interferon, cyclosporin, and IVIG in controlling the gastrointestinal manifestation. But given the lack of strong evidence supporting the routine use, these treatments should just be considered as fourth-line option for gastrointestinal involvement. I'll present to you the French recommendations. I picked up what I thought important for us to know in the management of Behçet's disease. We'll start with a case of active Behçet's disease in a young man calls for alert and careful monitoring. These patients are at greater risk of severe complications. The buccal and genital aphthosis must be objectified by a physician distinguished from other causes. The presence of perianal aphthosis is rare and must trigger the exclusion of inflammatory bowel disease. Articular involvement, as previously mentioned, is most often oligoarticular and not destructive. It readily affects lower joints and more rarely the spine. And if there is an axial damage, the spondyloarthropathy should be ruled out. Ocular involvement is potentially serious and requires systematic seeking. The uveitis of Behçet's is never granulomatous, and every posterior uveitis must be treated with systemic corticosteroids and immunosuppressant, and in severe cases, the introduction of corticosteroids and anti-TNF is justified. Interferon alpha is an alternative therapeutic option. If there is unexplained fever or biological inflammation in Behçet's disease, there should be a search for a complicated or severe organ involvement, such as cardiac or vascular. Cerebral thrombophlebitis justify a search for intracranial hypertension, which can be overlooked in this situation, but it can lead to optical atrophy and blindness. In the presence of meningoencephalitis, particularly in the brainstem, infectious causes must be searched for carefully before attribution to Behçet's disease. We should know that superficial venous thromboses often precede deep venous ones. Venous thromboses of Behçet's disease are of inflammatory type, and the prescription of anticoagulant is controversial, but may be considered in adults during the acute phase and in the absence of risk of hemorrhage, particularly related to arterial aneurysms. The occurrence of venous thrombosis in children and young adults justify the search for other causes of thrombophilia. The corticosteroid sparing is an essential objective in treating Behçet's, particularly with the corticodependent character and the frequent use of it during the relapses. So we should have an aim of corticosteroid sparing agent use. Any uncontrolled Behçet's disease must prompt the investigation into a lack of therapeutic compliance. Colchicine is the first-line treatment of mucocutaneous and articular manifestation, and this must be continued for a minimum of 3 to 6 months before judging its ineffectiveness. The dose must be adapted to renal and hepatic function, and its prescription must involve precautions regarding drug interactions and grapefruit consumption. Reduction or discontinuation of immunosuppressant can be considered after at least 2 years of remission within the framework of severe Behçet's disease, except in exceptional cases. but treatment discontinuation requires expert advice. These were most of the most important point in the French recommendations published in 2021, February 2021. And finally, because of the high incidence of the vital organ involvement, regular follow-up and appropriate management of Behçet's disease is mandatory. And because of its multi-systemic nature, collaboration among related specialties to improve the patient outcome is required. I hope you find it useful. Thank you.
Is she available for questions? So I stand corrected. Nowhere has rituximab showed up in her recommendations. My reasoning was as follows. This is a very non-compliant patient. So I thought trying